Thank you for joining us. Today, we'll be discussing healthcare transformation, the shift from volume to value, and specifically, finding the upside opportunities so that healthcare organizations can survive the sea of change under the Affordable Health Care Act.
I think one of the things is there's a tremendous amount of uncertainty in healthcare. We can all agree on that. Hospital CEOs are trying to not only get fiscal house, but physician alignment. One of the mistakes I would say is that physician employment doesn't equal alignment,
Right.
and you really got to back to everything we've been talking about, which is everybody having a voice in the table. So here's the math problem I was alluding to. We talked a little bit about defensive medicine and costs. Every day now in the paper you're reading about the lack of or the ability to deliver mental health services. We have huge number of people that need these critical services but not enough beds. Our primary care deliverers, we've talked about nurse practitioners and PAs being huge component, important part of that workforce going forward. But we're still at ratios where to deliver on the acute care side, we're still shortfalls.
Right.
What Ron was talking about was, we have 30 to 40 million new people coming in the system, 75 million boomers that are complex, they take multiple medications, require a lot of follow-up. And they are seeking access elsewhere.
That's
and
right.
When we come back and we end and we talk about innovation, that's where a lot of the innovation and where we can learn from other industries. One of my personal things, just from a risk thing, is we are trying to incentivize people not to admit, not to readmit, to order less tests. I think this is going to be difficult to do in the boomer population because of the comorbidity and mortality. We're going to have to figure out for that population better ways to take care of them. And we've talked about this already, the hub and spoke problem about if you do get these healthcare systems or practices in, how do you make sure you have consistency? To your point, communication. Will my electronic healthcare record talk to their electronic? And the bottom line is, these things take time. It takes, we're talking about integrating healthcare systems is not going to happen overnight. So one piece of advice I would say was take a deep breath. We have a common saying in the emergency department, when there's an emergency, the first pulse you take is your own. So everybody take a deep breath. And I am a glass is half full, but there are a few winners that have nailed this, and what can we learn from them? These are some of the emerging risks, sort of where the puck is going. I think some of these new technologies you talked about, are we going to see new standards of care in healthcare delivery? Will we be held accountable for not using the latest and greatest technology? Drug shortages. How are we going to make do that the drugs that we traditionally used to take care of people are not necessarily available? What is it that's going to take leadership? And I would go back to, we are stewards of this process. And the right healthcare leaders are going to look at other industries and they're going to realize that if I could articulate a vision that everybody could get behind, and I ensure good communication, but I empower people to have disruptive technology and bring it in, telemedicine.
Absolutely.
So, telemedicine, the estimates are 30% of healthcare delivery. To Ron's point about access.
Yep, absolutely.
So we're going to need to figure out innovative ways to increase access, and the public's going to drive it.
Yep.
I'm glad that you ended on innovation because I actually want to move on to innovation. Innovation, experimentation, nimbleness, disruption. Those are the words, those are the buzzwords that I'm hearing regarding healthcare transformation today. It's a challenge because healthcare organizations are facing financial constraints, and it's kind of hard to be innovative when there's increasing regulation. So I want to start with Ron. What does it mean to be innovative and disruptive in healthcare? What does that look like?
Well, first it requires in my opinion, a high level of self-awareness, and know what you're good at and what you're not good at. And so when to Graham's earlier slide, in trying to estimate where the puck is going, are you going to be a population health manager, or are you going to be a clinical destination? And that kind of dictates which path you're going down. Once you understand the path you're going down, probably the best thing I could say is be very open to innovative ways to engage with the patient on the front end and on the post-acute side. Now, one issue, just very quickly about post-acute, I think I don't want to leave without referencing the post-acute world that we have right now. It's under the stressors that are very similar to what Graham just alluded to. If you just look at the dementia population now, 12.5 million seniors with one of the 47 forms of dementia. And we only have, if you add skilled nursing, assisted living, LTACs, STACs, and et al., it roughly foots to about 4.6, 4.7 million total post-acute beds. Well, 30% of that 12.5 million population of dementia patients need to be facilitated, about 40% need to be supervised. We're woefully inadequate in our post-acute infrastructure just to deal with the dementia population. We're not even talking about the top 15 chronic conditions. So we've got as we're asking acute care to drive higher levels of acuity into lower level care settings, we have some vulnerabilities on the post-acute infrastructure front too. So all that to say, I think we need to really, a chief medical officer of a client of ours said it best. He said, Ron, the music industry's been through it, major transformation. Their fundamental revenue models changed. The publishing business has fundamentally changed. It's just our turn. So I would argue that whether you're a population manager or a clinical destination, you need to be very open to alternative ways of reaching out and identifying the patient, the member, and pulling them into the system and discharging them, because there'll be very, very disruptive models on both sides of that will be emerging.
By pulling them into the system, I've actually seen Walgreens do it already,
Absolutely.
not even with patients alone. If you go ahead and submit your tracking data, they'll go ahead and give you a couple dollars off of your soda pop or off of your medication.
Absolutely.
So I see what you're talking about with respect to innovation. Now, Kim, you had mentioned nimbleness earlier. That is quite the challenge, knowing that evidence-based practices are going to be changing and that payment models are going to be changing. Please give us your insight on how do we become nimble? Do we go back to the operating system to plug in the ability to move and flex and stretch and bend?
I think the engagement of physicians and the physician specialty societies will be probably the leaders in terms of that nimbleness. In the past, there had been, the definition of what outcomes we needed to look at that were done, CMS, Joint Commission, high level. We're really bringing that down, so each of the societies are saying these are the things that we need to pay attention to. And when they become more nimble by kind of putting a stake in the ground, I think we'll be able to achieve better outcomes.
I completely agree.
Basically, what I'm hearing from this conversation is that there's 1,000 ways to skin a cat, that healthcare transformation isn't going to resolve on its own without a variety of different strategies and methodologies is what I'm hearing. But one area of opportunity that you mentioned earlier, which Ron earlier reinforced, is the fact that there's a lack of standard operating systems. I do want to go back to innovation one more time. One story that I recall is a story, I'm going to have to come back to Silicon Valley here, is the story of PayPal. PayPal actually started off or was envisioned as an encryption service. And after starting the business model, they had to fall down a couple of times. And now today they are the big default payment system. So what I'm hearing from the panel today or from Ron's comments is that leaders need to be self-aware and need to step out of the box and be willing to try and take risk. Is that what I'm hearing as far as innovation?
I think so. It's a hard thing to do in a healthcare delivery system. I think we get trapped in trying to put out the fire of the day. And I think what you're alluding to is we need to change our mentality. And the organizations that are nimble, that can drive innovation and give a platform to execute it. Because I think we could all sit in a room and have great ideas on some of these challenges, but executing them, particularly across a population, that's going to take some time. And so one thing I would add to that is start to think in terms of developing countermeasures, not just solutions, because they're going to be a wave of new technologies, new problems. So can you as leaders develop a way to think and react that allows you to turn the Titanic? Because some of these institutions can you turn the Titanic? And the way I would look at it is not everything is applicable across the platform of healthcare. So I would use the ivory towers example. There's some shining examples of healthcare systems that are doing it from soup to nuts really well. But you may not have the resources, you may not have the infrastructure, the IT to do it. So grab the parts you can and adapt them and adopt them in order to drive innovation in your own healthcare system.
So I want to ask him a little bit about that. Dr. Billingham made a comment regarding building that into your processes again, the ability to adapt. Can we talk a little bit about that within the quality realm?
Sure. I mean, the ability to adapt
And
to be
innovate in the quality realm.
Innovate in the same space takes, effort. And you have to be very specific about those efforts. So the whole idea about how do you embrace innovation is not just coming up with a grand idea and implementing it. It's really being very purposeful about what are the types of things that you want to be able to innovate on. And one of the things I would like to point out is that we're seeing a lot of emerging markets around innovation in healthcare that have not happened before. Really exciting stuff. There's an innovation conference now, Mayo Clinic sponsors, Medicine X at Stanford, another great, vehicle. And I think we're going to start to see more and more outside groups looking at how they can innovate in the healthcare space. What we need to be able to do is to be open to that and to be able, actually willing participants to trial some of those innovations. So I think that, we'll look at emerging technologies to help us innovate. And then the other piece is back to the frontline clinicians, is really around communication and engagement for them. And if you can innovate on the technology side and you can innovate in how people work together, then I think those two things coming together is where hospitals and health systems are going to end up being more successful.
Okay, so
Completely agree. Yeah, and a lot of that is bottom up, like you said. A lot of those
Exactly.
innovations are out in the field. We have a client that struggles with a midwife scenario in a rural part of the state, and it was through a series of dialogue. We actually, Dr. Henry Lerner is developing shoulder dysplasia in partnership with Google Glass. So the midwife can keep her hands on the patient, never leave the patient, and have the video walk her through how to deal with a shoulder dysplasia issue. That was a kind of a ground up, and the institution's trying to rapidly adopt that without, getting hung up on the evidence-based piece of it. So therein lies the challenge. It's a real issue. It's a real issue. And I would just ask the audience to take this in the spirit which it's intended. Owning more assets on the ambulatory side and the primary care side or the post-acute side does not necessarily make you an integrated system. It gives you the ability, just like dealing with those organizational issues, dealing with those leadership issues. It gives you the ability, but grinding through narrowing that variation is a whole nother game.
any comments?
I completely agree. And you're going to have to solve technology issues, communication issues, and again, I think we've said it. It's probably worth saying again. Is just because you have coverage doesn't mean there's access out there. Just because you have consolidation doesn't mean that you have continuity. And just because you have employment, that doesn't mean there's alignment. So I think there's some fundamental
Really good point.
themes that are happening out there in the healthcare world. And I think this takes 6 to 10 years to sort through. It's not going to happen overnight. Look around within your own institution. There is a cost to sitting still. I wouldn't advise anybody to sit still. This train is moving, but at the same time, pick and choose. Don't put your head in the sand, and start somewhere. And start somewhere with a consistent process that empowers people to have a voice, and then prioritize those things that are going to drive efficiency and better care and improve quality, while you're keeping your eyes on the cost dial. And if you want the clinicians, the physicians, I'll wear my physician hat at the table. Be transparent with us. Give us all the data. Let us be part of the data. Give us a seat at the table. I mean, I've heard it said many times we're both part of the problem and part of the solution. And we have the power of the pen in the sense that we're ordering all these, tests and stuff. So I think getting the clinicians on board, we're trained to be skeptical of data. And so we'll ask hard questions, but I think if we have good data and we have a seat at the table, we can be part of this.